In this presentation, we are going to learn about electrocardiography. At the end of this practical, you will be able to understand how the electrocardiography is taken and how it is interpreted. Our learning objectives are: after this practical, you will be able to define the electrocardiography, perform an electrocardiography recording practically, analyze the electrocardiography waves, calculate the rate, rhythm, and cardiac axis on the electrocardiography trace, and determine the electrocardiographic pathologies. Electrocardiography is a recording of the cardiac electrical activities from the body surface. The horizontal axis of the electrocardiography paper shows the speed, and each small square's time is 0.04 seconds. The vertical axis shows the voltage or amplitude, and each small square corresponds to 0.1 millivolt. The speed of an ideal electrocardiography recording is 25 mm per second. In electrocardiography, we make recordings and there are leads connected to the body. So two types of leads are used to record the electrical activities from different aspects of the heart: extremities and chest. First, extremity leads. There are two types of limb leads. First, bipolar limb leads. Lead 1 between right arm and left arm. Left arm is positive. And lead 2 between right arm and left hood. Left hood is positive electrode. And lead 3 between left arm and left leg. And left leg has positive electrode connected. And unipolar limb leads. Augmented voltage right. In this recording, other extremities are connected via 5000 ohm resistance, and the exploring electrode is connected to an extremity. Others are combined. So augmented voltage right means exploring electrode is connected to the right arm. Augmented voltage left, now left arm, it is connected, and augmented voltage foot, exploring electrode is connected to the left leg. You see here the electrodes: D1, positive electrode in the left arm, D2, derivation 2 or lead 2, in this case right hand, right arm is negative and left leg is positive, and in derivation 3 again left leg has positive electrode connected. Here you see the derivations and D1, 2 and 3, D2 and D3, and examples of recordings. Here you can see in the D1 P, QRS and T waves are followed, and in the different size, as you see. D2 quite parallel to the cardiac axis. That's why generally it is the highest R wave among these. Chest leads. V1, in chest leads again there is exploring electrode and others from other extremities coming electrodes are combined after 5000 ohms the other side. So V1 fourth is put on fourth intercostal space in the right sternal border. Here I I should say that the manubrium sterni and corpus sterni connection corresponds to the second intercostal space, so that we can easily determine the fourth intercostal space. V2 on the left hand side, and V3 between V2 and V4. V4 left fifth intercostal space in the mid-clavicular line, and V5 left fifth intercostal space in the anterior axillary line, and V6 left fifth intercostal space in the mid-axillary line. You can see here the locations of precordial leads, V1 to V6, fourth intercostal space on the right hand side, on the left hand side, and V4 fifth intercostal space in the mid-axillary line, and then V3 between these two, and V5 anterior axillary line, and V6 middle axillary line, fifth intercostal space. You can see here augmented voltage right, left, and foot. Generally, in augmented voltage right, P wave will be negative. It is normal, and you can see the chest electrode recordings here. As you see here, connections. Okay, after 5,000 ohms, this is the other side recording, and this is exploring electrode. Changing the positions precordially and also to the extremities. If it is connected to the extremities, we record augmented voltage of extremities, as you see here. To understand how these waves are formed, I recommend you to read Guyton and Hall textbook of medical physiology about electrocardiography topic. If a wave is coming to an electrode, it records upwards and positive, and the size of the wave corresponds to the voltage amount. Okay, so it goes down, it means that it's going away from this electrode. Tools and materials used in electrocardiography recording. First, electrocardiography machine and chest and limb electrodes and gel are needed for this practical. You can see here an example of electrocardiography, electrodes, extremities and precordial ones, and also the gel. How to record? First, patient's information needs to be entered. If there is any metallic objects on the body, like belt, watch, wallet, telephone, etc., they should be removed. And after lying over the table, the patient's chest should be exposed to lessen the skin resistance, and electric gel is applied to the connection sites of the electrodes. First limb leads and then chest leads are connected. After making a control recording with the machine, the electrocardiography recording is performed. So the P wave is the wave of atrial depolarization, and the duration of it is less than 0.12 seconds. Amplitude is 0.25 millivolts. QRS wave represents the ventricular depolarization. It also covers atrial repolarization. That's why we don't see atrial repolarization wave in normal electrocardiography. Normal duration is between 0.06 to 0.12 seconds, and the amplitude is between 1 to 1.5 millivolts. T wave represents ventricular repolarization. Normal duration is 0.15 seconds. Amplitude must be less than 0.8 millivolt in the limb leads and 0.3 millivolt in the chest leads. So this paper speed is 25 millimeter per second, so about 0.04 second between these two lines, small square lines as you see here, and then 0.20 seconds in large lines, bold lines, normal lines and bold lines. When we are calculating the heart rate, we use these lines, okay? Between our squares, if we use large lines or bold lines, we divide it in 300 divided by how many bold lines between our lines. So PR interval represents duration that conduction of the signal from synatrial node to the Purkinje fibers. It is the distance from the beginning of P wave until the beginning of Q wave. Normal duration is between 0.12 to 0.20 seconds. QT interval represents ventricular depolarization and repolarization times. It is the distance from the beginning of Q wave until the end of the T wave. Normal duration is between 0.35 to 0.40 seconds. ST interval represents the duration from complete ventricular depolarization until the beginning of ventricular repolarization. It is the interval between the end of S wave until the beginning of T wave. Okay, you see here QT interval, ventricular depolarization and repolarization including, and then PR interval from the beginning of P wave to the beginning of QRS complex. You see a normal electrocardiogram here, derivation 1, 2, 3, and augmented voltage right, left, and food. As you see, P wave is negative in augmented voltage right because it sees the atria from upwards and the right hand side. And then V1, V2, V3, and V4, V5, V6. V4, V5, V6 generally see the heart from the left and downwards, and they see the heart from the anterior side. We can calculate here the heart, how many times the heart beats, pulse rate I mean, okay, 1, 2, 3, 4, so 300 divided by 4, about 75 times per minute approximately in this case. Now commenting on electrocardiogram. First, isoelectric line is checked if it is fluctuating, and then it is checked whether the electrocardiogram recording is properly done. Is there any artifacts? For example, all leads are present or not, recording speed is properly adjusted or not, electrodes are properly connected or not. And waves are evaluated in relation to their shape, duration, and amplitude. Rhythm is determined, and then if the rhythm is sinus rhythm, how to understand that? We check the P waves. If the P waves are present, then the rhythm is sinusal rhythm. Is it rhythmic or arrhythmic? Calculating the heart rate is important, and cardiac axis should be calculated using at least 2 limp leads. Maybe D1 and D2 generally are used, and normal axis in an adult is about 59 degrees, but it varies quite a large range. And to determine presence or absence of pathology, Rhythm. The presence of B wave indicates a signal of sinus rhythm. RR interval is measured in several leads of the electrocardiogram. If the measured RR interval is equal, it is rhythmic electrocardiogram. If the RR interval is not equal in any of the leads, then it is called arrhythmia. Here you see two electrocardiogram, and in A you see a rhythmic electrocardiogram. The intervals between R waves seem equal, whereas if we look at the intervals in B, they don't look equal. For example, here about 3 large square, and then here 4 large square intervals. So this is an arrhythmic electrocardiographic pattern here. So calculating the heart rate. Heart rate is in the electrocardiogram is calculated by counting the number of squares between two R waves. If we use small squares, we count intervals between the R waves, and then we use that number. We divide 1500 to this number, so to get heart rate. Or if we use large squares, we use 300. So normal heart rate is in the range of 600 to 100 beats per minute. Heart rate that is more than 100 is called tachycardia, and heart rate that is less than 60 is called bradycardia. You see here a bradycardic electrocardiogram, and then a tachycardic electrocardiogram. As you see here, if it is, let's say, 2 large squares, then 300 divided by 2, here 150 times heart is beating. And then if we look at here, 1, 2, 3, 4, 5, around, so if we divide 600 to 5, it is less than 60 times per minute. When calculating the heart rate in arrhythmia, all QRS waves in 30 big square in lead 2 should be counted and multiplied by 10. Or heart rate can also be calculated by counting the QRS waves in 15 large squares in lead 2 and multiplied by 10. Limb and chest leads provide information about anatomical regions of the heart. Accordingly, electrocardiogram recording from particular leads can be associated with particular regions of the heart pathologies. Here you see the leads. As you see, lead 1 or derivation 1 sees the lateral wall, lead 2 inferior, lead 3 inferior, and then augmented voltage right from the upper part, and augmented voltage left from the lateral wall of the myocardium, and then advantage voltage foot inferior part can be followed here. V1, V2 septal events can be followed, and V3, V4 anterior part of the heart, and then V5 and V6 lateral part of the heart can be followed if you look at here. So in cardiology, these are important. Which part of the heart has a pathology, for example, myocardial infarction. Determining the cardiac electric axis. It is the mean of the electrical activities of the heart as a whole. Normal cardiac electrical axis is plus 59 degrees. Cardiac axis can deviate due to physiologic or pathological causes. Physiological axis deviation. Physiological axis ranges from minus 30 to plus 120 degrees. In extreme thinness or during deep inspiration, the anatomical position of the cardiac apex can deviate to the right, and therefore the cardiac axis also deviate to the right. Whereas in obesity, during pregnancy and during expiration, the axis may deviate to the left. Now, pathological axis deviation. The electrical signal is conducted more slowly in the pathological side in comparison to normal side. In cases like right bundle branch block, right ventricular hypertrophy, pulmonary stenosis, and advanced mitral stenosis, there will be right axis deviation. In cases like left ventricular hypertrophy, systemic hypertension, and aortic stenosis, axis will be deviated to the left. In figure 8, lead 1 shows the horizontal axis and augmented voltage foot shows the vertical axis. In lead 1, the height of the QRS complex is shown with a number of small squares above the isoelectric line taken as positive values, while those under this line are taken as negative values. So we get a value and we make a mark in lead 1, and the same thing is applied for augmented voltage foot, and then we by 90 degrees dots we form. I will show you in the picture so that you will understand better. The electrical axis of the heart is determined by marking the direction of the vector sum on the figure. So I can tell you that here I can show you. First, let's say this is D1 and this much, and then this is the voltage foot, this much, okay, and then 90 degrees by 90 degrees we go this way, then we come this way, and then this is the electrical axis of the heart, right? This is the electrical axis of the heart. So calculation is made this way. Now, pathologies. Myocardial infarction. Myocardial infarction is a tissue injury caused by coronary artery vessels, occlusion. Coronary artery occlusion. Electrocardiogram waves can be seen in 3 sequential stages: ischemia, infarction, and necrosis. In ischemia, this situation is seen as a result of failure in blood supply to the tissue by the occluded vessel. Electrocardiogram shows a negative T wave. The patient describes this condition in the form of a knife stabbing pain on the region corresponding to the apex of the heart, and this is called angina pectoris. You see electrocardiogram, negative T waves in ischemia. Now, subendocardial ischemia. As a result of coronary vessel occlusion, ischemia is first seen in the subendocardial area. In association with this, ST segment depression is seen. You can see here ST segment depressions, PQRS, T, ST depression can be followed here in lateral subendocardial ischemic patient in lead V and lead augmented voltage left. ST segment depressions are followed here and here. And finally, the most important, infarction. It describes the tissue damage which occurs after ischemia. Electrocardiogram finding is ST segment elevation, like mosque dome or minaret. Here you can see in inferior myocardial infarction in lead 2, 3 and augmented voltage foot, ST segment elevations. This is the isoelectric part, and then ST segment is elevated, and this way you can see in D2, D3 and augmented voltage foot. If an electrode records this wave in just opposite, then the ST segment depression can also be followed instead of elevation seen in these electrocardiogram derivations. Necrosis. After infarction, the tissue will not return to normal and will degenerate. A sign of deep Q wave will be seen. Normally, Q wave depth should not exceed 1/4 of the QRS complex height. So you can see here the Q wave left after myocardial infarction in augmented voltage foot, as you see here. Also Q waves can be followed here. Now atrioventricular blocks. It is a situation in which the signals arising from the synovial node to the ventricular muscle delay or do not pass at all through the atrioventricular node. There are 3 types of atrioventricular block. First degree atrioventricular block, prolongation of the PR interval. Normally the PR interval should not be more than 5 small squares. The conduction of signals to the ventricles is delayed. Here you see prolonged interval, so this is the first degree atrioventricular block, prolonged PR intervals can be followed in electrocardiogram. And second degree atrioventricular block, sometimes atrial impulses cannot reach the ventricles. This can be seen in 2 forms. First, type 1, Mobitz 1 or Vancouver phenomenon, gradual prolongation of the PR interval until the QRS become absent. As you can see here, progressively prolonged PR interval, so this is the second degree or type 1 atrioventricular block. Here it's not transmitted, so these are prolonged PR intervals, and then it's not transmitted to the ventricles at all. So this is the second degree atrioventricular block. P wave VC, we don't see QRS followed. Type 2, Mobitz 2, gradual prolongation of the PR interval at certain intervals. There will be a failure of conduction to the ventricles. For example, out of 3 signals arising from the synovial node, only 2 passes to the ventricles. This will be 3, 2, 1. This flow must be the same all the time. According to the figure below, respectively, a single signal originating from the synovial node is conducted to the ventricles while the second signal is not. That is why it is called 2-1. Here you see that 2 degrees or type 2 atrioventricular blocks. We don't see following waves here. Third degree block, atrioventricular block, Adams-Stokes syndrome it is called, because none of the synovial node generated signals pass to the ventricles. The ventricles will start to generate pacemaking impulses independently, but at a slow rate. Therefore, the ventricular and atrial rates will be different. They are independent of one another. There is no regularity and patient is unconscious. You see third degree atrioventricular block here. There is no QRS wave following. Here again, there are no QRS waves following. Change PR intervals can be followed. Very short, very long. And fourth, Parkinson-White syndrome. In this case, we have a short PR interval. Normally, the PR interval should not be less than 3 small squares. If it is less than 3 small squares, passage of the signal through a way other than atrioventricular node taking place. The electrocardiogram finding will be in the form of a delta wave. You can see here very short PR intervals seen in Wolff-Parkinson-White syndrome. Atrial arrhythmias. First, atrial flutter. The impulse arises from two different foci. This is a commonly seen situation in atria because the impulse arises from two different foci in the atrium. Beside the normal P wave, at intervals, multiple similar P waves are seen. Heart rate increases between 250 to 300 beats per minute. In electrocardiogram, a characteristic saw-teeth appearance can be seen, as you see here, saw-teeth appearance in atrial flutter. And ventricular arrhythmias, ventricular fibrillation, the most dangerous arrhythmia. It occurs because the signals arise from more than one focus. This is a commonly seen situation in ventricles. The signals arise from different multiple foci. Typical electrocardiogram signals are not seen. Heart rate is higher than what is seen in flutter, more than 350 beats per minute, and the prognosis is worse because there is no real pumping action. The patient loses consciousness and can die if cardiac massage is not applied, if electroshock is not applied. You see here ventricular fibrillation, an electrocardiogram representing ventricular fibrillation. There are no B waves, no QRS waves, etc. It's irregular waves, no pumping action. Ventricular extrasystole, premature ventricular contraction, we also call it. These impulses causing this pathology are normally absent and arise from ectopic ventricular foci. They continue shortly and then disappear. Drinking coffee, cigarette, being under stress, and having irregular sleep are among the causes of premature ventricular contraction. When the risk factors are removed, it generally improves. In electrocardiogram, suddenly an extra QRS complex appears with higher amplitude and longer duration in all leads. There is no P wave before this QRS complex. As you see here, totally different waves can be seen. This is extrasystole, and as you see, this is normal QRS, P and QRS, P and QRS. There is no P here. This is extrasystole. Now, electrocardiographic findings in changes in the potassium and calcium concentrations in plasma. The changes in the concentrations of some ions in plasma are reflected in all electrocardiogram leads, but these electrocardiogram changes are different from the electrocardiogram changes due to disorders of certain parts of the heart itself, since the electrocardiogram changes due to disorders of certain parts of the heart itself are seen in particularly some derivations. First, hyperkalemia. Hyperkalemia is also called as hyperpotassemia. Normal blood potassium level is between 3.5 to 4.5 milliequivalent per liter. The most striking sign of electrocardiogram is tall and peaked T wave. Other electrocardiography findings include long PR interval and wide QRS duration. So, hypokalemia or hypopotassemia. In hypokalemia, the T wave amplitude decreases. In severe hypokalemia, T wave is sometimes flattened and even become negative. U wave appearance is quite typical. U wave, which is caused by delayed repolarization of papillary muscles, also evident in ventricular hypertrophy. So you see here normal plasma values, normal electrocardiogram. In hyperkalemia, you see the T waves amplitudes of T waves are increased, whereas in hypokalemia T waves are different, U wave is formed, T wave may be depressed. Hypercalcemia, blood calcium level normally varies between 2.4 to 2.7 milliequivalent per liter or 8.5 to 10.2 milligram per deciliter. In hypercalcemia, tachycardia and short QT interval are striking, whereas in hypocalcemia, there is bradycardia and prolonged QT interval. Here you see a normal electrocardiogram, and then in hypocalcemia there is bradycardia, and in hypercalcemia there is tachycardia is seen. Bundle branch block, it is caused by a delay or obstruction of electrical impulses along the left and or right bundles. The electrocardiogram shows RR pattern and wide QRS complex. This situation of RR wave is called rabbit ear appearance. If the RR pattern is seen in V1, V2 and V3, it indicates right bundle branch block, while if it is seen in V4, V5 and V6, it indicates left bundle branch block. You see here V4 and V5, so RR pattern, so it shows us left bundle branch block in this patient. Now ventricular hypertrophy. Ventricular hypertrophy is seen in diseases like hypertension and aortic stenosis, as well as in physiological conditions like in athletic people. The typical electrocardiogram sign of ventricular hypertrophy is increased QRS complex amplitude. The deepest S wave in V1 and V2 is chosen. R wave with the highest amplitude in V5 and V6 is chosen. Amplitudes of the selected S wave and R waves are added to each other. The sum of R wave and S wave is more than 35 small squares. Then left ventricular hypertrophy is considered. Moreover, if the depth of S wave alone in V1 and V2 more than 26 small squares, then left ventricular hypertrophy is also considered. The largest R wave in V1 or V2 is chosen. The deepest S wave in V5 or V6 is chosen. The amplitudes of the selected waves amplitudes are added to each other. If the sum of R wave and S wave is more than 10 small squares, then right ventricular hypertrophy is considered. Moreover, if the amplitude of the R wave alone in V1 or V2 is more than 7 small squares, and then left ventricular hypertrophy is also considered. Now you see left ventricular hypertrophy, S wave here, and then the R waves here. If you combine them, if it is over 35 small squares, we can say there is a left ventricular hypertrophy. Here you see the problems when you are recording electrocardiography. So device recording settings can be damaged. You should set it normal values, amplitude and the speed should be set. And the presence of metallic materials should be removed from the patient. They can cause artifacts. Electromagnetic interference in the area can affect the recording. You should stop instruments, or you should go somewhere else. Conducting gel is applied to a further side, so electrical conductance can be disturbed. Improper connection of the electrodes, yes, if there is a problem with connection, you cannot record properly. Electrode connection sides to the body are exquisitely hairy. If there are so much hairs on the body, then it may be difficult to record, especially on the chest. And patient movement during recording can cause artifacts. And why electrocardiogram is recorded? What are the aims? Now the review questions. Why record it if the patient's heart is beating normally? Is there a rhythm problem, or is there any ventricular hypertrophy? Also, is there any myocardial infarction or ischemia situations, or is there any reflection of blood potassium and calcium level changes? How is the heart rate is calculated? So if you use large squares, you count large squares between R waves, and then 300 divided by the large squares, you get heart rate. Or if you count small squares, 1500 divided by small squares will give you the heart rate. How is the cardiac axis is determined? What are the conditions in which axis deviation take place? Yes, cardiac axis can be determined using D1 and augmented voltage food. You subtract, you count positive and negative waves, squares, upwards and downwards, and take net number and put it on the graph, and you have to use at least two D1, D2, D1 augmented voltage food, etc., and then see when they come together. Okay, they reach the lines taken 90 degrees to their size, and then connect the tip with the zero line, and then this shows us the cardiac axis. Normal cardiac axis degrees 59. It may range quite a range. Left axis deviation and right axis deviation can occur in different conditions. Let's say in hypertension, in aortic stenosis, left axis deviation can occur, or pulmonary hypertension, right axis deviation can occur. So describe electrocardiogram signs of myocardial infarctions. Yes, in myocardial infarction we see ST segment elevation or depression according to the site the electrode sees the infarct area. What are the leads for inferior and lateral ischemia? I think augmented voltage food, and V4, V5, I guess can see, but we should check from the text. Okay. So thank you very much for listening, for watching this electrocardiography lab presentation.